Welcome guys to this Harrison-based MCQ discussion series which is going on currently, which has been done in a such a fashion that completion of MCQ is leading to completion of the chapter. Today we are going to focus on a very common topic commonly seen in OPD practice both for the medicine people or the MBBS graduates or you are postgraduate resident. This is very much common for you to know and understand about it. So this chapter deals with gout along with crystal associated arthropathies, but for now we are going to focus on things as gout, right? So understanding of the disease improved hugely in the late 1960s with the advent and discovery of something known as polarized light microscope and other X-ray crystallography technique. Thanks to this great scientist Hollander and McCarthy, who are the giants of this field in the arthritis topic, along with the rheumatology topic as a whole, and they are the great in their fields for the discovery. They were the first to observe those crystals under polarized light microscopy, which lead us to foundation of pathogenesis, foundation of understanding of the topic, right? Okay, so they were the one who dealt mostly with crystal associated arthropathies like CPPD disease. All right. So what does polarized light microscopy help us? Suppose suppose a 65-year-old male comes to you with complaints of severe joint pain. Severe joint pain that is disabling in nature involving the knee joint. Now remember, although knee joint is seen in pseudogout, that is CPPD disease, but it can be seen in gout as well, knee joint involvement. So how do you differentiate? You can only differentiate by assessment of the gout fluid, aspiration of the fluid in the knee joint, and understanding it, observing it under polarized light microscopy. Otherwise, you cannot differentiate between them. That was the importance of this technique, and which help us to identify the pathogenesis and also guide the treatment. Right. So what does it help? It helps to mainly differentiate between the types of crystal associated arthropathy, like differentiate between gout versus pseudogout, mainly based on the type of crystal which accumulates in gout. Monosodium urate or uric acid excess case leads to monosodium urate crystal. In pseudogout, there is deposition of calcium pyrophosphate crystals. Beside this, there are other crystals that has been mentioned like calcium oxalate or calcium apatite, right? All of those are involved in this chapter, right? Now, why it is important to differentiate? Because it helps us to guide the therapy. Okay, all right. Also, assessment of fluid, joint fluid is very much important to rule out an important differential of this case that is known as septic arthritis, which also present with severe pain, disabling joint pain, unable to move the joint, as well as fever. But fever will be higher grade compared to gout. Okay. So coming to the first MCQ of the day, first MCQ from the topic proper. So it says, which of the following crystal cannot be reliably identified by polarized light microscopy alone? Note, from here, we have learned from age old, like important thing that we have learned in pathology as well, that monosodium urate or gout leads to needle shaped negative bifurcations in polarized light microscopy. Whereas pseudogout or CPPD disease leads to rhomboid shaped weakly positive bifurcations. Right. Now, what do you mean by negative bifurcations or positive bifurcations? Negative, remember, it gives yellow color on bending of the light, whereas positive gives blue color on bending, right? So you know CPPD or MSU, both of these crystal can be identified by polarized light microscopy. Therefore, CPPD and monosodium urate both are ruled out. Remember guys, calcium apatite is not visible under polarized light microscope. Very important point for MCQ exams, right? Calcium apatite is not visible. Rather, calcium hepatite requires electron microscopy to identify or use of special staining. Okay. So this calcium oxalate stones are very rare, usually seen only in case of settings of background settings of renal failure, and it gives a shape of envelope or bipyramid. Okay. So what are the different shapes that we need to know? Different shapes we need to know about calcium oxalate, shape of the calcium oxalate, what shape it does, monosodium urate and calcium pyrophosphate. So calcium pyrophosphate gives pseudogout. Pseudogout is rhomboid shaped, weakly positive. What do you mean by weakly positive? Means blue color. Gout or monosodium urate is due to needle shaped crystal. Needle shaped crystals are negative bipyramidals. What do you mean by negative bipyramidals? That it gives yellow color, imparts yellow color. Now, calcium oxalate is very rare. It is seen only in case of renal failure, in the setting of renal failure, and it is envelope or bipyramidal shape in nature. All right. Okay. So, moving to next MCQ. So, which of the following is not typically involved in the crystal-induced degradation of joint structure? Now, what happens is this crystal arthropathy. Suppose this is the joint. This is the joint, right? There is some reason, for some reason, there is excess of the crystals in the body or the source of the crystal. For example, there is excess of uric acid in the body, which gives a inactive deposit. Inactive deposit mainly in the synovium or the joint spaces. But for some reason, this inactive deposits sheds off into the joint. This shedding of this inactive deposit leads to a chain of reaction which ultimately causes acute flare up in the condition like gout or pseudogout. This triggers inflammation. It triggers inflammation which we call by the term inflammasome, and the key cytokine involved in it is interleukin 1 beta, right? So interleukin 1 beta is the key cytokine involved. Why actually this inflammation or inflammasome occurs? Because this interleukin 1 beta is associated with reduction of uric acid level. It has been said that interleukin 1 can reduce uric acid almost 2 milligram per deciliter. So that's enough to reduce the burden of the uric acid in the body, right? Okay. Beside this, due to inflammation, body will come into natural physiological protective phenomena in which the joint will not move and joint will stay in the resting position, and which in time will prevent more shedding of those crystal into the joint space. Okay. So what does it interleukin 1 beta or this crystal in the joint space causes? It causes damage to the cartilage. This damage to the cartilage and joint is through physical irritation, like ongoing inflammation, and this ongoing inflammation leads to release of multiple enzyme in the form of metalloproteinase, collagenase, and prostaglandin E2. Remember, it is prostaglandin E2. These three are the common enzymes which are secreted and which ultimately will lead to chronic destruction of joint. Now, so as you can see in the question, which of the following is not typically involved in the crystal-induced degradation of joint structure? Metalloproteinase, yes, it is involved. Collagenase is involved. Prostaglandin E2 is involved. Histamine is not commonly seen in this joint-mediated diseases. Therefore, antihistaminic has no such role in prevention of the disease as well as prevention of the pain associated with. Okay. So moving to the next question. So it says which of the following is key cytokine? Clearly, we have seen the key cytokine is interleukin 1 beta. All right. Okay. So So this is all about crystal associated arthropathy. Now we are moving into more detailed discussion about the topic proper, which is our gout. All right. So this crystal associated arthropathy can have varied presentation in the body. It can present like acute arthritis episode, mono, oligo, or polyarthritis episode, periarticular inflammation in the form of bursitis, tendinitis, or enthesitis, or deposition of tophi, which is seen in mostly in the late stages. Right. There can be chronic arthropathy related changes, destructive arthropathies, or there can be spinal arthritis, even deposition of those crystal arthropathy or crystals in compartment may lead to carpal tunnel syndrome. All of those can be varied presentation. Usually, most commonly, it starts with monoarticular presentation, right, which in turn leads to oligo or polyarticular presentation. So, what is gout? Gout is a disorder in which there is high level of uric acid in the body. That is the most important thing you need to know. So high level of uric acid is prerequisite. But remember, most importantly remember, during the acute flare, as there is release of interleukin 1 beta, this uric acid will come down low for a brief period of time during acute attack, resulting into almost pseudo normal, or the report may come to be as normal, but although there is no normal uric acid value at that time, therefore giving a false impression that uric acid is not high. So uric acid high is a prerequisite, minimum requisite to have a gout pathogenesis, but sometimes in acute flare, uric acid normal values can be normal, right? Okay. So this is one prerequisite, and this prerequisite uric acid gets deposited as monosodium urate crystal into the joint cavity. Right? Into the joint cavity, and as well as the connective tissues along with it. Classically, it presents as episodic inflammatory arthritis. Like, it is not a chronic in nature or only acute episode in nature. It is episodic. It happens for a time. Then there is intercritical period when there is no attack of gout at all. Patient is absolutely fine, and there is again a bout of attack of gout. Usually, there are some precipitating factor present in it, like alcohol intake, purine-rich food intake, or there are some drugs which patient might be on currently, for which this gout attack happens, right? Okay. And this gout attack causes disabling pain, severe pain, most commonly seen in middle-aged men. All right. And middle-aged men, and if 10 people of gout are coming to our OPD, 9 will be middle-aged men, 7 to 8 out of them will be nothing but alcoholic, and only one will be female. That also very rare, only in setting of something like condition like CKD. So it is so rare in the female patient. Now, among those 10 patients, remember 7 to 8 will have only first metatarsalophalangeal joint involvement, first metatarsalophalangeal joint, which is also known as podagra, right? Okay. So 90% are male, middle-aged male, 10% can be female, 70 to 80% will have first metatarsalophalangeal joint involvement, and in female, it will be postmenopausal female rather than the premenopausal one. And postmenopausal female, not only postmenopausal, there will be setting present like on drugs or like conditions like chronic kidney disease. All right. Okay. So that is all about the etiology. Now consider gout to be something to be due to increased uric acid level in the body. So there is first and foremost, most importantly, increase in the urate pool. Increased urate pool. And why does there is increased urate pool? Increased urate pool is due to chronic hyperuricemia. Now there is a some point we will come to the points later, but some point when there is saturation point is reached, this uric acid get crystallized. Compare this to adding sugar to the tea, right? Tea is the synovial fluid and sugar is the uric acid level. Like when there is excessive amount of sugar you are giving, some of the sugar will settle down in the bottom of the cup. Similarly, when there is excessive amount of uric acid in the body, this is freely floating in the synovial fluid, but suddenly some amount will start crystallize and deposited in the joint cavities, right? This crystallized urate or monosodium urate deposits in the joint and tissue, resulting into acute inflammation, and if untreated leads to chronic gouty So acute inflammation and untreated lead to chronic gouty arthritis. Chronic gout arthritis along with persistent synovitis or erosive bone and joint damage. So these chronic monosodium urate deposits can erode joint cartilage much like rust eats away a metal. Okay. So does it happen to all? No, it doesn't happen to all. There should be some etiological risk factor which causes increase in urate level. There should be some of the causes like cardiovascular metabolic comorbidities like obesity, age, even hypertension, diabetes, or MI, stroke, or urate nephrolithiasis, like those comorbid condition, which which increases the chance of formation of crystallization of the urate. And there are some modifiable risk factors, including obesity, mainly Western diet, alcohol, sedentary lifestyle, and use of diuretics. All of those are modifiable risk factors. Now, one question might come, or better, you should know that gout is reported among primate only in human. Now, why only human or why only humans develop gout? Like humans are the only mammal to develop spontaneous gout because we lack something in our enzyme system known as uricase. Maybe you can consider that to be evolutionary gift or mistake. An enzyme which breaks the urate into allantoin, which is water soluble. So, uric acid is not broken down into water soluble allantoin, therefore it is not excreted from our body. So this evolutionary loss of uricase enzyme lead to formation of gout in human beings, right? Okay. So all, but having said this, remember all hyperuricemia cases doesn't lead to gout. Hyperuricemia is necessary for formation of gout, but it is not sufficient to cause gout. Only a minority of people with high uric acid level develop symptom. So all doesn't develop high uric acid level, and whenever someone develop high uric acid doesn't mean they are going to develop gout. There should be other factors involved. There should be predisposition factor, there should be triggers like trauma or dehydration or the change in pH level, and which will lead to formation of those gout crystals or monosodium urate crystals, right? Okay, so as you can see, there are some risk factors like obesity. Obesity is for the people who are currently doing MBBS. Remember, this is a risk factor, and postgraduates, remember this with term, give a more fancy term for you, that is insulin resistance syndrome. All right. Then there are factors like diet or alcohol intake and something that is carried in our genes or intake of drugs like diuretics or low dose aspirin. All of those conditions leads to increase in the uric acid pool in the body, and when a certain level is reached, certain level that is beyond critical level for formation of gout, beyond 6.8 milligram per dl, there is formation of crystallization of those urate or monosodium urate crystals, and it gets deposited into the tissue. Now this crystallization is also precipitated by certain factor like pH, mainly acidosis, then it can be due to intra-articular dehydration. Imagine in a cup you are giving 5 to 6 spoon of sugar, right? So when the sugar will crystallize and deposit in the below part of the cup, only when you are giving excessive amount of sugar or you are taking out the water. So when there is dehydration in the joint space, the amount of crystal present gets deposited, resulting into gout flare. Now this also needs a trigger for this gout flare. So what are those? These are purine rich food, again alcohol or diuresis, local trauma, even start of urate-lowering therapy, which are usually the treatment of chronic hyperuricemia like allopurinol or febuxostat, may precipitate acute attack of gout. And when there is recurrent gout attacks, it leads to chronic gouty arthritis. Remember, when there is acute attack, treatment is not urate lowering. When there is acute attack, you need to give symptomatic relief. Symptomatic relief in the form of anti-inflammatory therapy. We will come to detail later, but remember the thing that we need to give in acute attack is anti-inflammatory therapy. Whereas when there is crystallization phase or when there is chronic gouty arthritis, we need to go for urate-lowering therapy. Urate-lowering therapy with target of urate level of less than 5 to 6 milligram per dl, and it should be pain free for minimum 2 to 3 month duration, maximum up to beneficial up to 3 to 6 month duration. Okay, so that's all about the pathogenesis about gout. All right, so coming to the next question, all of the following are typical triggers of gout flare except. So we have seen alcohol consumption is trigger, high purine diet is a trigger, diuretics is trigger, methotrexate, no, methotrexate is not a trigger for gout. All right. So here in the question, which of the following statement about gout in women is true? So premenopausal gout is common. No, it is absolutely rare. Although there are case reports there, here and there you can find, but it is absolutely rare. Gout is more common in premenopausal women than this is also false statement. It is more common in postmenopausal rather than premenopausal. Most women with gout have comorbidities like hypertension and renal disease. Yes, that seems to be true. And women represent more than 50%. Again, it is also false. Women is around 10% of the total cases of gout. Now, remember, premenopausal gout is very rare, almost absolutely not seen, but still, there can be case reports present. And if you get some cases, you need to get diagnosed it in the form of joint aspiration, and obviously you get a chance to publish the case, right? So, don't think in premenopausal woman, premenopausal female coming to joint pain as a gout. All right. Okay. So coming to the next question, what is the typical duration of gout flare if left untreated? So understanding this is very important. Remember, most common joint involved is first metatarsalopharyngeal joint involvement. First metatarsalopharyngeal joint involvement, which is also known as monoarthritis or podagra, podagra, and joint involvement can be remembered in the following fashion, like podagra is the number one joint, followed by tarsal joint, ankle joint, and knee joint, right? So these are podagra followed by tarsal joint, ankle joint, and knee joint. And the patient will have severe disabling pain. Severe disabling pain, very severe in nature. Sometimes it mimics cases of pseudocellulitis. But thing is that which is very much important to understand. However, the pain is, it responds very well to NSAIDs, even OTC NSAIDs, right? This NSAID should be given at high doses, but it responds generally responds well, and even it responds to glucocorticoids. So even if it is left untreated, within 1 to 2 weeks, it heals by itself. Therefore, the pain is getting relieved with NSAIDs, which often the patient takes, and within 1 to 2 weeks, the pain relieves. So, person will have many such episodes of recurrent pain in which the patient will take the anti-inflammatory medication, quickly take the anti-inflammatory medication and get relief. So, there will be multiple episodes of recurrent attack, ultimately leading to chronic gouty arthritis, right? Okay. And between the two phases of attack, there is a phase patient will be absolutely normal, absolutely fine, not worried about the disease. In most of the cases, we leave the urate-lowering therapy thinking that his treatment has been completed. This phase is known as intercritical period or intercritical gout. Like so, for in the situation in India, understand that for middle-aged men, who are the chunk of the patients with the gout, when they have acute flare, if they visit doctor for the first time, they, which is also real, like for middle-aged men in Indian scenario, to visit doctor for the first time with the pain is real. They obviously will go for some OTC medication or to quarks and take NSAIDs, and NSAIDs will give a quick relief. And once they know NSAID is giving the relief, after second or third attack also, they will again buy the same NSAIDs, take this OTC medicine, again get relief. Ultimately leading to a stage of chronic gouty arthritis, so which is very commonly seen in India. Even for example, if the patient went to doctor, if the doctor gives gives the patient urate-lowering therapy. This urate-lowering therapy has chance of increasing the gout attack, right? So therefore, the patient will feel that instead of taking ULTs or urate-lowering therapies like allopurinol or febuxetate, it's better to only take NSAIDs, and he will continue taking NSAIDs and leave febuxetate or allopurinol, which again leads to the state of chronic gouty arthritis in near future. Therefore, counseling the patient at the very first time when they come to your visit, come to your OPD, that you don't need to leave the medicine, you need to continue medicine, otherwise there will be stage that joint will be deformed if you look it unlook, and there will be multiple episodes of recurrent attacks. So find your trigger in your diet or in your habit and change the habit, right? Whether you are taking purine rich food or whether you are taking alcohol excessively amount, just change the habit so that you feel better. Even reduction of weight also has a very good role. All right, okay, so we need to target those modifiable risk factor in the management of this gout patient. So having said this basic understanding, let's move into something known as how do you diagnose gout. Now, this is not given exclusively in Harrison, but understanding this acute gout diagnosis rule is very important. So, sometimes even clinical features suggest nothing but gout. A strong clinical suspicion is there of gout. Still, sometimes needle aspiration is mandatory. Why it is mandatory? Because CPPD disease can have similar presentation, pseudocellulitis or septic arthritis can have similar presentation, but if we check the treatment differs very much. So, do you go for joint aspiration in all the cases? Therefore, therefore, to avoid joint aspiration in all of the cases, some rule, a prognostication rule and marker has been laid down known as acute gout diagnosis rule based on the factor which are the most important risk factor for acute monoarticular arthritis. Now, points like male, previous attack of gout, acute onset like more less than 1 day, inflammation in the joint, past MTP involved, history of hypertension or cardiovascular disease, and serum uric acid level more than 5.8. Together, if score is less than 4, gout is unlikely. 4 to is indeterminate, and more than 9 or more than equal to 8, gout is likely, and you straight away try with treatment, right? When it is 4 to 8, things get dicey and you need to go for joint aspiration. Joint aspiration to check for the crystal types. Okay. All right. Okay. So here, as you can see in this risk factor scoring, serum uric acid level has been given the maximum point followed by 2.5, that is fast metatarsophalangeal involvement, which is also known as podagra. Okay. All right. So synovial fluid in acute gout is expected to show which of the following finding. Now remember, when we aspirate the synovial fluid, it is usually cloudy in nature because there is increase in level of leukocyte in case of gout, typically in the range of 5,000, can go high up even up to the 75,000, right, per microliter, and maybe due to this leukocyte, due to this cloudy nature, it can be thick, pasty or chalk-like appearance due to presence of large crystal burden. Now, for this reason, sometimes joint fluid culture is essential, and it is essential also because if you suspect something like bacterial infection in the joint. Now, joint fluid culture is sought for this reason sometimes. Utility of arthrocentesis or joint aspiration is that it can be done in non-inflamed joint. For example, it can be done in knees and it can be done in intercritical phase for diagnostic yield, right? So, for example, if you are suspecting something of gout, you are giving medication, treatment, still there is multiple relapses. There is recurrences, multiple time recurrences, and you are confused. As a doctor, you are confused because you are giving a proper treatment plan. Patient is planning going for proper treatment plan. They are also following the diet as you have advised, but still there is multiple recurrent attacks. In such cases, you can obviously go for arthrocentesis in intercritical period. That is when there is no pain at all in non-inflamed joint like knees, and check for what kind of appearance, what kind of crystal is present to make the proper diagnosis. So, what is the most likely Expectation in the synovial fluid, it is cloudy fluid with elevated leukocyte and count. Hemorrhagic fluid with RBC and no crystal will be seen in only traumatic cases, right? Traumatic cases or hemophilic arthropathy. Now coming to the next question, a 55-year-old male presents with acute monoarthritis of the right first metatarsophalangeal joint, which is also known as the podagra. So you can see there is podagra involvement, male patient, and that is acute history. Acute history, all of those are pointing towards gout only based on the risk factors of the acute gout diagnostic role. And when microscopy was performed, it showed needle-shaped crystal, most likely finding. So needle-shaped crystal, it is nothing but monosodium urate. What kind of finding it is seen? It is seen as a negative bifidobacterium. So synovial fluid in analysis, the gold standard for diagnosis, needle exploration of involved joint or tophi can be done. Now, presence of needle-shaped monosodium urate crystal, which can be seen both intracellularly and extracellularly, which is negative bifidobacterium under polarized light. Okay, all right. So, as you can see here, what is it? So, there is two type of crystal examination, and this is the something image given in polarized light microscopy. So, in normal image event, normal light microscopy, you can see this is the needle shaped crystal available, and polarized light microscopy, you can find this needle shaped crystal are yellow in color. So, yellow means negative, correct? Okay. So, here in this image, you can find there is rhombus like crystal, and these rhombus like crystal are blue in color, that is positive bifidobacterium. All right. Okay. So, let's revise a flashcard for now. So, what does it says? It says a serum biochemical evaluation. So, what are the lab tests that you go for a patient with gout, right? So, serum uric acid may be low normal during acute periods due to dash induced uricosuriia. What is it? It is interleukin 1 beta induced uricosuriia, and it can go down by 2 milligram per dl. Not reliable during flares, better to assess historical and past flare levels. Okay, that's why in case of acute flare, it's better not to go for uric acid level. If you're suspecting clinically gout and your score is going above 8, eyes closed, you start straightaway treatment. Now, chronic dash is required for pathogenesis. Obviously, chronic high uric acid level more than 6.8 milligram per dl is required for pathogenesis, even if transiently absent during flares. So, what are the baseline investigation needs to be done? It is mainly for the evaluate the patient for comorbidity like LFTs, hemoglobin, WBC, HbA1c, diabetes, and lipid profiles. Right. It helps the gout related risks and monitor therapy side effects. Okay. So, so this is all about the biochemical finding. Now let's move into the radiological finding. So radiological finding is only seen in advanced stages of gout. Now here you can observe very clearly there are cystic changes in multiple places. There is cystic changes as well as some overhanging margins, right? Overhanging margins which give red, white appearance. There are some sclerotic margins as well as, and in the soft tissue region you can see tophi. Okay, tophaceous masses. So what are the finding that can be seen in x-rays only in advanced cases? What are those? These are cystic changes, number one. Then there is erosions, number two. There can be sclerosis, number three. and overhanging edges, which is also known as Martelji sign or red bite erosions. There can be also tophaceous masses available. All of those are radiological findings. All right. Okay. So, X-ray findings seen in obviously in case of late gout, and overhanging edges is known as red bite pattern. There can be soft tissue tophaceous masses, cystic changes, well-defined erosions, sclerotic margins. Now, this is about X-ray. Now, when to go for MSK ultrasound? MSK ultrasound helps in early detection via specific sign over cartilages. This sign is known as double contour sign. Okay, so there is one margin of the joint as well as another margin due to the monosodium urate crystal deposition can be seen, known as the double contour sign over the cartilages. Right. Then dual energy CT, it helps to identify MSC crystal based on specific chemical signature. It is helpful for confirmation as well as extent mapping, right? Remember, this can be considered in future as a non-invasive method to identify crystal. Okay, so it is something in research recently. It is the non-invasive method. CT scan, dual energy CT scan is a non-invasive method to identify crystal pattern. Coming to next question, a 56-year-old man present to OPD with complaint of severe joint pain in the big toe with history of multiple similar episodes. So it is middle-aged man, severe joint pain in big toe, that is first metatarsophalangeal joint or podagra, multiple similar episodes. So this is recurrent episode. All of this is features of gout. Now USG is done. First metatarsophalangeal reveals this characteristic finding. So what is the finding? You can see there is very well defined double contour. So it is double contour sign. All right. Okay. So what is it actually? It results from the urate crystal that coats the normally anechoic hyaline cartilage. So this hyaline cartilage around the joint cavity appears black, usually appears black in USG because it does not reflect the ultrasounds, right? But when there is deposition of urate crystal, this anechoic margin or otherwise black colored in USG becomes white. Okay, and also you can obviously see the bony contour. So this bony contour and contour due to the urate crystal deposition resulting into something known as double contour sign. So where is double wall sign seen? Double wall sign is also known as regular sign seen in cases of pneumoperitoneum or acute abdominal pain. Okay, so where is our cases of double density sign seen? Double density sign is due to enlargement of left atrium over right atrium, and any case associated with left atrium enlargement like mitral stenosis or late stage of mitral regurgitation or left atrial myxoma or congenital condition like VHD or PDA, there can be double density sign. All right. So, so this is about double barrel sign. Double barrel sign is known as double barrel shotgun sign. It is due to obstruction at the level of the distal common bile duct, right? And all of this results into dilatation of portal vein. So portal vein and the CBT duct almost appears to have the same length, and it gives the appearance of the double barrel of the shotgun, right? It is seen mainly due to cholelithiasis or pancreatic head tumor. Okay, so these are the most common causes of double barrel sign. All right. Now let's move into the treatment part. We have discussed gouts in flashcard in the form of discussed about different biochemical markers we need to check, different radiological investigation we need to check. We have checked the MCQ. Now we are going to flashcard in the revision in the treatment part of the gout cases, right? So there is some non-pharmacological measures which can be tried. Non-pharmacological measures involve like ice pack application or giving joint a form of rest. Now, NSAIDs, colchicine, glucocorticoid are the three important pharmacological measures for acute treatment. Beside this, there is another thing known as anakinra. We will obviously look into that. And for recurrent cases or chronic cases, we need to go for urate-lowering therapy. Alright. So, what are the main classes of NSAIDs used? Remember, NSAIDs when used should be used in high doses or maximum possible doses. For example, for indomethacin, dose is around 50 milligram TDS, which is the maximum dose. For naproxen, it's 500 milligram twice a day. For ibuprofen, we usually prefer 800 milligram thrice a day. And for celecoxib, initially we give for 800 milligram stat dose, followed by 400 milligram BD. Okay, so this is the usual dosage. Now, beside this, there is choice of colchicine. Colchicine is something should be given first dose as 1.2 milligram stat, followed by 0.6 milligram as when required based on the pain present or not. Right. Okay. So colchicine is effective if given early, and colchicine is preferred low dose regimen, whereas NSAID is preferred to be high dose regimen and start early in the flare onset in case of NSAID, and continuation of anti-inflammatory NSAID is required until there is complete resolution. So issue with NSAID is that it should be avoided in case of renal, cardiovascular, or peptic ulcer disease, renal complication, which is also very much common in gout. Right. Okay. So colchicine, whereas should be started as a low dose. It is better tolerability and preferred over NSAID. It is given as 1.2 milligram initially, then 0.6 milligram within an hour, followed by maintenance based on response. But issue with colchicine is that it is metabolized by something known as P-glycoprotein or MDR1, multi-drug resistant 1, in our body, and which inhibitor, if used, should be used cautiously with colchicine. For example, if clarithromycin or tacrolimus is used, it should be used cautiously along with it. Right. Okay. So when is glucocorticoid preferred? Glucocorticoid can be and the only drug which can be given as IM injection for pain relief. Right. Beside this, it can be given in the form of intraarticular injection as well or oral form as well. Right. Okay. So initial dose is prednisolone for 30 to 50 milligram per day, then it is steppered accordingly. It is useful mainly in polyarticular gout where more than one joint is involved and patient on NSAIDs on colchicine not relieving, right? Also, it can be used in monoarticular gout if you are planning to give intraarticular steroid injection, right? Now, when all of those treatment modality fails, what we have is known as interleukin 1 antagonist like anakinra, right? It is only preferred when patient is refractory to the standard treatment, or refractory gout is the choice in which anakinra we should try. Okay. So coming to this question, 70-year-old man on tacrolimus developed acute gout. Which drug should be avoided or used with caution? So obviously we know tacrolimus is nothing but P-glycoprotein inhibitor, and it increases CYP3A4 inducer, so should be used in caution. Along with the drug which passes through it. Drug which passes through it is colchicine. Now, which of the following is the target serum urate? We have already checked. Target serum urate is 5 to 6 milligram per dl. Now, urate-lowering therapy is aimed at correcting chronic hyperuricemia. Chronic hyperuricemia, which was the underlying cause of gout, right? Now, in gout, we normalize the serum urate level to less than 5 to 6 milligram per dl, and it is required for preventing recurrence of attacks, right? It is used for preventing recurrences of gout attack, gout flares, or eliminating the tophi if at all present. So, ULT is given, urate lowering therapy if given, it should be given lifelong. Now, once you know the indication, what is indication? It is chronic hyperuricemia, tophaceous changes, or when you need to prevent recurrence of gout. All of those are indication of urate lowering therapy. You need to know what to initiate urate lowering therapy. So, before that, let's solve this question and understand when to initiate. What is the indication to initiate urate lowering therapy? So, when there is hyperuricemia, you don't straightaway start on urate lowering therapy. First, advise the patient to modify risk factor. Modify risk factor in the form of reduction in weight, change of diet, or abstinence of alcohol. Like if there is no improvement of uric acid level with weight control, healthy diet, or reduced alcohol intake or fructose intake, avoiding medications like thiazide and loop diuretics, still uric acid level are high, like 9 or 10, and still there is chances of recurrent attack you can feel, then obviously you start on urate lowering therapy. Now, suppose the patient was successful in lowering the uric acid level, but still there was attack of the gout. Attack of gout not only once, at least for around 2 attacks per year is still happening. In such cases, also you need to start the urate lowering therapy, or the attack which was there, attack maybe one in a year only, and but it is severe, prolonged, disabling type of attack. So, which leads to poor quality of life, and you have counseled the patient properly, patient is ready, committed to take the medicine for the lifelong. In such cases, also you can start urate lowering therapy, and presence of tophi, irrespective of tophaceous gout or chronic gouty arthritis, irrespective of the serum uric acid level, becomes indication. So, let's check into the MCQ again. So, which of the following is indication? Single mild gout attack? So, absolutely not. More than 2 attack per hour, attack per year is the indication. Asymptomatic hyperuricemia, no, it is also not indication. If there is recurrent attack of gout with hyperuricemia, that becomes indication. Presence of tophi, obviously. First degree relative with gout, no, it is not. So, answer is presence of tophaceous gout. So, let's revise some of the flashcard in the form of the urate lowering therapy, so that we understand the topic proper about gout management, right? So, we have discussed a lot till now regarding what is the uric acid pathophysiology, mechanism in the body, how the gout presents, how only why male are more commonly presenting in the OPD, how they present with the pain, what are the features of the chronic gout, what are the X-ray changes, what are the biochemical marker change expected, and we have checked about the therapy in the form of acute management. We have checked about the indication of steroids and indication of starting urate lowering therapy as well. Now, moving into the urate lowering therapy, the first and foremost, most important one, that is allopurinol. Allopurinol is also, that is the xanthine oxidase inhibitor. It is the first line agent along with feruxostate. Now, dose should be started with around 100 milligram per day, and it should be titrated up to maximum of 800 milligram, right? And what is the target serum urate? We have studied once again and again. It is 5 to 6 milligram per day. Now, remember, in CKD patient, you need to start allopurinol at low doses and titrate more gradually. So, in CKD patient, it should be started at 50 milligram and titrated slowly. Why so? Why so? Because in CKD there is decreased elimination of allopurinol from the body, so resulting into staying of the allopurinol in the body in the blood for the maximum point of time. Now, if you give higher dose at very fast instant, remember this urate lowering therapy leads to shedding of the urate crystal into the joint space, joint cavity, resulting into flare of the gout. So, This is a paradoxical reaction that can be observed. Therefore, it is always better to start at lower dose, let the body get habituated with the medicine, and gradually titrate the dose to the level till which desirable result is achieved. What is desirable result? Desirable result is total serum urate to be 5 to 6 milligram per day. Okay, but when you start allopurinol, remember there is obviously chance of severe cutaneous adverse reaction known as scar, and there is around if you 2% risk. So if you are starting allopurinol in 100%, 2 patient can live into scar. Scar is very dangerous condition, which is nothing but Steven Johnson syndrome or 10. Okay, so this can happen 2 out of the 100 patient that you are starting on allopurinol. Therefore, it is not ideal to screen each and every individual to check for potential complication. But in some individual like Southeast Asians or black peoples, you need to screen for uh, the HLA, which is associated with severe cutaneous adverse reaction, and HLA is HLA B5801. All right. Okay. So, moving to the next one. Next one is febuxostate, which is alternative xanthine oxidase inhibitor, and it is used if the patient is intolerable to allopurinol. All right. Okay. So, if there is HLA B5801 positive mutation cases, or the patient is intolerable to allopurinol, you need to start for febuxostate. Now remember, liver metabolizes febuxostate by glucuronide conjugation. Okay, so it is metabolized in liver. Therefore, hepatotoxicity can be seen initially with start of febuxostate. Okay, so but benefit is that there is no need to dose change in CKD cases. Now, talking about the first line, we have only two medicines, that is allopurinol or febuxostate. Mostly allopurinol should be used, and if allopurinol is not tolerable to the patient or there is HLF-B5801 mutation, in such cases you can go for febuxostate. Now, what are the second line agents? Second line agent are uricosuric. Uricosuric are which causes renal excretion of the uric acid from the body. So it increases the renal urate excretion and used in normal renal function state. So what is the PET uricosuric drug? PET uricosuric drug is probenecid. It is used in 250 milligram twice a day, titrated to 3 gram per day. It is ineffective if creatinine is more than 2 milligram per day. Naturally, right? If there is creatinine is rise, there is renal function is compromised. Obviously, renal urate expression will be compromised. There is no value of giving uricosuric in such patient. Other uricase are like pegloticase, which is pegylated enzyme, which is reserved for use in the only refractory cases or when there is intolerance to other urate-lowering therapy. Okay. So, what are the other drugs which has been shown effective benefit? For example, among antihypertensive, we have got losartan over amlodipine. In the antilipidemic agent, we have fenofibrate, and also anti-diabetic SGLT2 inhibitor. SGLT2 inhibitor is in research currently for multiple factors. It has shown benefits, proven benefit in CKD patient as well as heart failure patient. So this SGLT2 inhibitor is also shown benefit in lowering the urate level. Most of the time questions are asked, antihypertensive of choice in case of patient of hyperuricemia, it is nothing but losartan. Okay, all right. So moving to the next flashcard. In the next flashcard, we will see the timing of ULT initiation. It is to be avoided starting during active flares, may worsen flare due to serum urate drop, can be started during resolution phase of flare. Now, when always use anti-inflammatory prophylaxis, that is pain relief should be targeted along with urate lowering therapy. Prophylaxis in the form of colchicine or naproxen. Naproxen in the lower dose. Remember, for treatment purpose, you used to give 500 milligram BD, but for prophylaxis, we are giving 200 milligram, 250 milligram BD. Right? Okay. Now, continue prophylaxis until patient got normal uric acid level or patient is gout free for around 3 to 6 months or until trophy which has been formed is resolved currently. So, all of those three are indication for continuation of prophylaxis, and this is the point when you know you need to stop prophylaxis of urate-lowering therapy. All right. Okay. So that's all about this chapter of gout. So in the next chapter we'll look into the another module. We'll also go into the same fashion as we are going as of now. We'll check into the MCQs, check into the subject proper, and everything will be based on Harrison. All right. Thank you.